Thrombocytopenia in pregnancy, references Dog article published in 2009. So what is the key content? That is thrombocytopenia occur in 8 to 10% of all pregnancy. In pregnancy, it is usually mild and benign. Rare causes can be associated with severe complication for mother and baby. Cases thought to be due to immune thrombocytopenia purpura or microangiopathic process should be managed in specialist center. We will start with introduction. Platelets are involved in primary hemostasis, plugging site of endothelial damage and acting as a surface for secondary hemostasis via the coagulation pathway. The normal semen level of platelet in pregnancy is 150 to 400 into 10 raised to the power 9. Reduction of serum platelet count is arbitrarily considered mild if the count is more than 100, moderate 50 to 100, and severe less than 50. So we will divide in this that what is mild, moderate, and severe thrombocytopenia. Low count can be due to increase in destruction or consumption of platelets, dilutional effect, or more rarely lack of production of platelets. So whenever the patient present with thrombocytopenia, low platelet count in pregnancy, so it could be due to dilutional effect that lead to thrombocytopenia. To sometime it is called as gestational thrombocytopenia and it is normal. So we have to monitor the patient. It is unusual to have a clinical sign and symptoms when the platelet count is more than 50 until platelet function is also defective. Common signs of thrombocytopenia include petechiae, nose bleeding, or more rarely hematuria and GI bleeding. During pregnancy, there is a general downward drift in platelet count, particularly during the last trimester. This results at term in a level that this is approximately 10% less than the pre-pregnancy level. The mechanism of this are thought to be a combination of dilutional effect and acceleration of platelet destruction across the placenta. Most women have still platelet count within normal range. However, if the starting count is at lower end of the normal range or there is more severe drop of thrombocytopenia occur, hence thrombocytopenia is a common finding in pregnancy. Most cases are mild and have no significance for mother or fetus, but in some instances when thrombocytopenia is a part of complex clinical disorder, this can be profound and even life-threatening result from mother and baby. So you have to assess that whether how much the platelet count is. If it is mild, then it could be due to, we will just monitor the patient. If it moderate or severe, then we have to rule out other causes. The effect of pregnancy on the disorder and conversely of the disorder on the pregnancy must be taken in account. Etiology and prevalence. A platelet count below the normal range is found in 8 to 10% of the pregnancy. About approximately 75% of these cases are due to benign process of gestational thrombocytopenia and 15 to 20 can be attributed to the other cause. So whenever the patient presented in pregnancy with thrombocytopenia and when it came as a short case, and along with that some other disease and having patient is having thrombocytopenia, so you have to first of all you have to tell in management you have to tell that 75% are benign causes and it could be due to itself as a pregnancy, because pregnancy is a dilutional process occur in pregnancy, and that's why low platelet count, and 50 to 20% lead to attributable causes. We will later on discuss that what are the causes for that, and you have to rule out these causes as well. Whenever the patient present with thrombocytopenia in pregnancy, you have to rule out other causes as well. So the first cause, it could be hypertensive disorder, 15 to 20%, 3 to 4% of an immune process, immune thrombocytopenia purpura. So in this case, the patient may have a previous history of early tendency to bleeding from gums and easy bruisability. So patient may have underlying causes of immune thrombocytopenia purpura, and the remaining 1 to 2% are up to rare constitutional thrombocytopenia, infection, and hematological malignancies. So you have to rule out other causes. It could be due to with the help hypertension. Along with help, there is low platelet count, so you have to evaluate the patient for hypertension, and could be the patient could be in DIC or other infections like malaria, dengue. They can lead to a thrombocytopenia. SLE, autoimmune condition like SLE, can cause thrombocytopenia, and the other infections, malaria, dengue, and the other acute fatty liver of pregnancy. In that case, there is also a thrombocytopenia, TTP, thrombotic thrombocytopenia purpura may present with thrombocytopenia. So in that case, you have to, these are the main causes, and you have to take the detailed history and rule out these causes, because 75% is due to pregnancy, but other rest of the percentage are due to some causes. Gestational thrombocytopenia. It is the incidental thrombocytopenia of pregnancy. It is which is most common cause of thrombocytopenia. 75% of the cases of thrombocytopenia and 8% of all pregnancy. It is a benign condition. There is no bleeding risk to mother or fetus. Counts are typically more than 70 or usually more than 100. So this is the reference rate for that. It could be usually more than 70 or usually more than 100. Many of the features are similar to mild immune thrombocytopenia, and it can difficult to distinguish between these two disorders, because in pregnancy you can identify by either due to gestational or immune thrombocytopenia. So whenever the patient got postpartum, after that you will evaluate for immune thrombocytopenia purpura, otherwise you will manage the patient as a normal gestational thrombocytopenia. There are no specific diagnostic tests for either, and both condition are diagnosis of exclusion. So ITP or gestational thrombocytopenia are diagnosis of exclusion, means there is no other causes, so your diagnosis would be ITP. If you cannot rule out other causes of thrombocytopenia, then your diagnosis would be in pregnancy, the first one gestational thrombocytopenia, or if it is not, then it will be ITP. Rarely, causes of gestational thrombocytopenia with platelet count as low as 50 has been described. Again, the outcome appears good. The pathophysiological process is not known, but it is thought to represent an acceleration of platelet consumption via an exaggeration of physiological process across the placenta, or possibly via a mild immune process. Gestational thrombocytopenia resolve quickly after delivery, but it can recur in subsequent pregnancy. A count should be performed 6 weeks postnatally and the result documented, because you have to rule out the ITP. So in that case, at postnatal, when all the pregnancy clotting factors and everything will be settled out, then you have to do a baseline platelet count, complete blood count at 6 weeks to exclude ITP. So we have discussed we have to discuss the table of this, that what are the causes. The causes of thrombocytopenia in pregnancy. The first one causes gestational thrombocytopenia is the physiological dilution, accelerated destruction. Third trimester usually present in third trimester. Platelet count should be more than 70. Incidental finding. ITP, immune destruction, suppressed production, and it is a diagnosis of exclusion. ITP, when other causes are ruled out, first would be in 75% cases gestational thrombocytopenia, but you are suspecting that this is not gestational, then your second diagnosis will be ITP, and it is a diagnosis of exclusion. So you have to keep in mind with that. The other one is thrombocytopenia, thrombotic thrombocytopenia purpura, and hemolytic uremic syndrome, peripheral consumption, microthrombi, unwell, fever, neurological and renal destruction. So these type of patient present with the low platelet count along with fever, neurological abnormality, and renal dysfunction, like the renal functions are deranged. HELP syndrome, peripheral consumption, microthrombi, raised LDH, ALT, bilirubin, hemolytic anemia, preeclampsia or DIC, hereditary thrombocytopenia, bone marrow underproduction. It could be in family history, abnormal platelets, pseudothrombocytopenia, laboratory artifact, platelet counts or blood film. So you have to, there may be, whenever you will do her complete blood count, and you will do her complete blood count, and it in that picture it shows that it is low platelet count, then for definitive diagnosis you will do manual platelet, you will take the blood from the patient and immediately check under microscope to confirmation of the so that is manual platelet count. For that test we will take the blood, and immediately under microscope we will check that whether the platelet count is truly thrombocytopenia or it is due to some artifact. Viral infection like multi-drugs, like you have to viral infection like malaria and dengue, and the other on drugs like the patient is taking any anti-TB drugs, anti-tuberculosis can cause thrombocytopenia in some cases, like rifampicin. viral illness, drug taken, risk factor, leukemia and lymphoma, bone marrow infiltration, abnormal film, enlarged liver, spleen, and nodes. So these are the causative causes of thrombocytopenia and pregnancy, and you have to take a detailed history to rule out other causes. If all the other causes are ruled out and they are not in the list, so in that case, your diagnosis will be idiopathic immune thrombocytopenic purpura. The first will be gestational thrombocytopenia and then ITP. For vast majority of the cases of pregnancy and delivery should be treated as normal. In case moderate or severe thrombocytopenia, and anesthetic consultation is useful to discuss analgesia options. Since most unit will not consider epidural anesthesia with platelet less than 80, a trial of steroid should be given when the count is 50 to 70. Count should be monitored periodically. When maternal count are less than 80 during pregnancy, a cord sample should be taken to ensure that the baby counts are normal. So whenever you are planning for that, if you are giving her epidural anesthesia, so the platelet count should be at least above 80. So the treatment of choice for if the platelet count, whenever the patient present, usually in first trimester, the at least 20, in second trimester at least 50 should be maintained, and in third trimester at least more than 70 should be maintained, because when we are planning for analgesia, for that analgesia you will maintain her platelet count of more than 80 at least. So if it is less than that, so you have to arrange the platelets and may need of if the count is less than 80, you are planning for epidural analgesia, then you will give platelets. And the first treatment of choice, if the you will involve the multidisciplinary team hematologist, and if the you will monitor her. If one reading is less than 100 into 10 is the power 9, so in that case you will to monitor her levels every weekly. If it is in downtrending, so in that case, in collaboration with the hematology, you will start her on steroid. Steroid is the best option in pregnancy. You will start her on steroid. Along with that, you have to rule out that patient is not diabetic, because it will further derange her sugar level. So before that, you will start her on steroid. If still on steroid it is not maintained, then you will the second line option is platelet transfusion or IVI immunoglobulins. So these are the second line treatment. So the first treatment, you will start her on steroid if it is downtrending. Steroid has a good response in to increase the platelet count. So whenever if and the other thing is that you will also observe the baby for you check the baby platelet count, and consider taking further neonatal sample on day 1 and 4, as neonatal thrombocytopenia can present then. When maternal platelet count are low, similar management to that of maternal immune thrombocytopenia purpura ITP is recommended because of the small risk of fetal thrombocytopenia. So there is chance that the baby, this is a ITP, and the baby may develop a neonatal thrombocytopenia, so you have to monitor the baby platelet count. However, where possible, fetal scalp electrode and sampling and high mid-cavity operative delivery should be avoided. Cesarean should be reserved for obstetric indication only. ITP, idiopathic thrombocytopenic purpura. Adult ITP is usually a chronic condition occurring among young women. The incidence is estimated 0.1 to 1,000 pregnancies, accounting for approximately 3% of the cases. So in normal thrombocytopenia, gestational thrombocytopenia, you will not start her on treatment. You will monitor the patient. But if you are suspecting that it is ITP, then what will we do? It is a diagnosis of exclusion. Although approximately 2/3 of the cases, that diagnosis is already established before pregnancy, allowing the opportunity for pre-pregnancy counseling. So sometimes the patient may present as a pre-pregnancy counseling for ITP, and sometimes the patient may with the thrombocytopenia, gestational thrombocytopenia. Then you have to rule out other causes. If other causes are not, and you are suspecting that this is not gestational thrombocytopenia, this is ITP, then you have to manage accordingly. The thrombocytopenia in ATP is predominantly caused by antibodies that are specific to platelet surface glycoprotein and which bind to platelets in the maternal circulation. So in ITP, the antibodies are formed against platelets, so that's why leads to destruction. So the mechanism of ITP is that. resulting in immune-mediated platelet destruction. Recent research suggests that there is also a suppression of platelet production. The antibodies can cross the placenta and can also cause fetal thrombocytopenia. Gestational thrombocytopenia can less likely cause fetal thrombocytopenia, but with ITP, there is chance that the baby may develop fetal thrombocytopenia because these antibody can cross the placenta and it will affect the baby platelets. Diagnosis: good understanding of the pathological mechanism. There are no specific diagnostic tests for ITP, although platelet can be demonstrated in these cases. The tests lack sensitivity and specificity, and therefore, the diagnosis of ITP is one of the exclusion. Careful history examination laboratory specimens are helpful in excluding other causes of thrombocytopenia. A bone marrow test is not indicated until there are unusual features or a lack of response to standard treatment. As a main, the difficulty is differentiation from thrombocytopenia. However, this is not often a problem clinically since no treatment is required for either condition when the platelet count is more than 70 to 90. It is unusual to have a less than 70 in gestational thrombocytopenia. So, in gestational thrombocytopenia, usually the platelet count should be above 1 lakh or usually more than 70. So, it is less likely that in gestational thrombocytopenia, the platelet can fall down so much that it is less than 70. But if it is less than 70, then you have to keep in mind that it could be ITP. So you have to involve the hematologist. If it's less than 70, then she may need treatment for that. So management with ITP should receive management in a unit with experience in care of this condition, obviously hematologist, and preferably in a common obstetric hematology setting. The aim of management is to maintain adequate platelet count that will minimize the risk of bleeding during pregnancy, delivery, and postpartum. Bleeding with ITP is unusual even with a low platelet count. So count should be closely monitored throughout the pregnancy. The majority of the women will not require treatment in the antenatal period. Therefore, it is often required to increase the count before delivery. The prednisolone is the usual first line choice and it is often administered at a low dose recommended for non-pregnant women to minimize the risk of adverse effect to the mother, gestational diabetes and postpartum psychosis. So a starting dose of 20 mg daily can be offered, escalating to 60 mg if no more an inadequate post process is seen after 1 week. So your initial dose will be start from 20 mg, then up to 60 mg you can given, and in that case you have to initially, you will not immediately, if the platelet count less than 70 and she's in second trimester, our main aim for second trimester is at least 50. First trimester, if more than 20 we will not do anything. If it in second trimester more than 50, so ideally in third trimester we will if it is less than 50, then we will immediately start treatment because she is near to delivery and at least we need more than 70,000 platelet count in that patient. But in second trimester, if it is up to more than 50, then we will serially monitoring. If it is downtrending less than 50, then we start, because we will start treatment immediately because it is in downtrending. So as initially you will not immediately jump to start her on steroid. You will first monitor her, because at the threshold level for the second trimester is up more than 50. If it is downtrending, then you will start her on steroid in collaboration with hematologist. Doses should be tapered to the minimum that is effective in maintaining the count within required range. When the count are very low, the woman has experienced hemorrhage or there remain inadequate response to steroid. IV immunoglobulins should be considered. It acts as a more quickly than the steroid. So the first would be our steroid. Second, you will give her immunoglobulins. And still if it is not working, then the third will be platelet transfusion. So these are the stepwise approach. Anti-D immunoglobulin appear to have efficacy equal to that of IV immunoglobulin for women those are Rh positive. Both of these options are useful when a rapid increase in platelet count is required. Other options are considered more rarely included splenectomy and platelet transfusion. So the first treatment will be steroid, second will be IV immunoglobulins, and the third, the least likely option will be platelet transfusion. Okay, so this is the feature of gestational thrombocytopenia, diagnosis of exclusion. No tests are available distinguished from non-immune. Mild thrombocytopenia, platelet count is usually more than 70. No associated maternal bleeding. No past history of thrombocytopenia outside pregnancy. Occurrence in third trimester. No association with fetal thrombocytopenia. Spontaneous resolution after delivery and may recur in subsequent pregnancy. So you have to differentiate from ITP. In ITP, usually the patient may have a history of easy bruisability, bleeding from gums, so you have to take the detailed history from the patient. So, what are the management of delivery maternal consideration? The main concern at delivery of the mother is the risk of hemorrhage. Although there are no universal agreed specific platelet count, there is general concentration that platelet count at least 50 is safe for vaginal delivery or operative delivery. When where the maternal platelet count approaches 50, platelets should be available on standby and management should be close consultation with a hematologist experienced in obstetric cases. The usual in that case, that the use of epidural anesthesia is a particular concern since it's a small. So, and antenatal or no invasive procedure planned, so the platelet count should be at least more than 20, for vaginal delivery more than 40, for operative and instrumental delivery more than 50, and for epidural anesthesia at least more than 80. So you have to maintain the platelet count at least in this range. If antenatally, usually in first trimester it should be more than 20, and second trimester at least more than 50. And for vaginal delivery, you need to the platelet count should be at least 40, and the operative instrumental more than 50, and for epidural more than 80. So, there is a controversy on the safe threshold for epidural anesthesia. In most institutions, a threshold of 80 is typical. An anesthetist consultation in later part of the pregnancy to discuss alternative analgesia is helpful. So, how will management of delivery neonatal concerns? Antibodies are IgG subtype that can cross the placenta and cause thrombocytopenia in the fetus and neonate. The main worry is possible intracranial hemorrhage in the neonate. This is extremely rare but devastating complication. The effect of antibodies on the fetal count is unpredictable. Maternal treatment near term with steroids or IV immunoglobulins do not have any effect on the platelet count, and there is no correlation between the severity of maternal thrombocytopenia and the fetal count. So they are telling about that these IgG will transfer to the baby and will destruct the fetal platelet count. So in that case, you have to be vigilant that if you are suspecting ITP and after for delivery of the baby, you avoid invasive procedure because risk of intracranial hemorrhage. The incidence of thrombocytopenia among neonate is 14 to 37%. Approximately 5% of the baby would have platelet count less than 50, and a further 10% have count of 20 to 50. Although there are no reliable predictable, fetal or neonatal thrombocytopenia is more likely if there has been a sibling with thrombocytopenia or the mother has splenectomy or platelet count have less than 50 during the pregnancy. So they said that the fetal and neonate are only be affected more likely when the sibling previous sibling having a thrombocytopenia and the mother have a history of splenectomy or she is having a platelet count of less than 50. Fetal scalp samples do not produce reliable count and should not be taken. No, there is no there and nor there is a role of percutaneous umbilical blood sampling since the procedure carries a risk of fetal hemorrhage and possible death of the approximately 2%. This is higher than the risk of intracranial hemorrhage, that is less than 1%. So you have to avoid. Once the baby delivered, then you will do her platelet count, cord blood sample for platelet count. Mode of the delivery, cesarean is not routinely recommended, and there is no evidence that it will reduce the incidence of intracranial hemorrhage among the susceptible babies. Measures should be in place to avoid trauma to the baby, and there should be avoidance where possible of fetal scalp electrode or sampling or high or mid operative deliveries. The neonatal tip should be altered to the possibility of thrombocytopenic baby before the birth. A cord blood should be sampled to assess the neonatal platelet count and therefore should be by capillary sample. You have to take the one once the baby delivered, then you have to send the cord sample, capillary sample for the platelet count. If the count is mildly reduced, further sampling on day 1 and 4 should be collected, but if initial result is normal, no further sampling is required. Obviously, if the baby platelet count is less than 20 or less than 50, then you have to check for another sample should be taken after on day 1 and then day 4. You have to repeat the sample. If the previous one are normal, not to repeat. If the previous one is abnormal, you have to repeat on day 4. IM vitamin K should be avoided until the count is known, and babies with severe thrombocytopenia should be treated with IV immunoglobulins. Cranial Doppler ultrasound can be helpful. Platelet should be administered in addition to IV immunoglobulin if there is life-threatening hemorrhage. So for baby, what you have to do, if IM vitamin K should be avoided, you will give her oral vitamin K, and in case of if the suspecting that the count is very low, then for baby you will give IV immunoglobulin, or cranial ultrasound before discharge is very important to exclude intracranial hemorrhage. So what are pre-pregnancy counseling? Where possible, it is useful to discuss the management issue that can be arise during the pregnancies. So what you have to do in pre-pregnancy counseling, they've given you a table that for women with ITP. These are we have discussed in pregnancy, but if she is already in pre-pregnancy came for as an counseling for ITP, so ITP may relapse or worsen during pregnancy. If treatment of ITP is required, it will carry both maternal and fetal risk. Around 1/3 of the women will require treatment at some stage of pregnancy, most commonly around the time of delivery. There is increased risk of hemorrhage at delivery, but the risk is small even if the platelet count is low. Epidural may not be possible, although it is not possible to predict adequately where the neonate will be affected. The risk is high if the sibling has a thrombocytopenia or mother have undergone splenectomy. So if she came as a pre-pregnancy counselor, you have to tell that how is her previous babies and what about her current status of the patient. Any splenectomy has done, because these patients at high risk that the baby may develop severe thrombocytopenia. So you have to take the detailed history of these patients. Maternal death or serious adverse outcome for mother with ITP are rare. The risk of intracranial hemorrhage for the fetus or neonate is low. So you have to discuss pre-pregnancy these points that the risk is low, and the treatment of child is obviously we have to start her on if the platelet count is downtrending. Maybe she's taking already steroids, so you have to adjust the dose in pregnancy. You have to tell her about that she may need later on immunoglobulins, may need of platelet transfusion. So there is obviously not a very simple pregnancy. It could be considered as a high risk pregnancy because platelet count anytime she can bleed with APH, PPH. So you have to tell the patient in detail that these are the risks to the mother and fetus, that the fetus may develop thrombocytopenia later on in neonatal age, and the mother may develop antepartum hemorrhage, increased risk of bleeding, increased risk of PPH. So these are the factors, risk factors you have to complication you have to discuss with the mother. In preeclampsia with HELP, diagnostic criterion of preeclampsia is a new onset hypertension, proteinuria of more than 300 mg per 24 hours or at more than 20 weeks of gestation. Estimated incidence is 5 to 10%, and the etiology not fully understood, but there is association with the presence of laboratory thrombophilia and genetic predisposition. There's increased endothelial cell activation leading to activation of platelets and the coagulation cascade. In general, women with preeclampsia have lower platelet count than normal, approximately 15% within the thrombocytopenic range. The condition rarely resolves quickly after delivery, therefore conservative management is appropriate for mild or moderate preeclampsia. Severe thrombocytopenia can occur among less than 5% of the women with preeclampsia, but it can be associated with DIC. So this require aggressive management and correction of coagulopathy with FFPs, cryoprecipitate and platelet transfusion. So whenever the preeclampsia and the patient may develop HELP, so you have to not treat them aggressively. No need of any platelet transfusion, steroid. So you have to manage the patient as early as delivery of the baby. So after the delivery, these levels are usually resolved. Everything will be fine after the delivery. But in certain case, for example, they are say that the patient may develop DIC, so in that case you have to treat her aggressively, otherwise treatment is not necessary. HELP syndrome, this is a condition combination of HELP, elevated liver enzyme, low platelet count, which can complicate severe preeclampsia in about 10% of the cases. It occurs more frequently in third trimester, but it can worse initially postpartum or occasionally present at time. The syndrome can occur without hypertension or proteinuria, and the diagnosis may be missed in these circumstances. The presenting sum can be very vague with nausea, malaise, epigastric or right upper quadrant pain. Staff should have high level of suspicion and check the full blood count and liver function test. So the pathophysiology of this condition involved endothelial damage with release of tissue factors and coagulation activation, and a full blood count show anemia and thrombocytopenia with the fragmented films on the blood film, microangiopathic hemolytic anemia. Liver function test should be raised, LDH, increased bilirubin, and abnormal liver enzyme. DIC may be present in 20% of the cases, and abruption can occur in approximately 16% of the cases. So the central nervous system and renal cells are usually unaffected by this condition in contrast to ATP. With ITP, there is chance that TTP, the chance that the renal system and central nervous system are involved, but with HELP, there is no involvement of neurological symptoms. The neonatal outcome depend upon the duration of gestation and delivery. Neonatal mortality rate consequent on the necessity of very early is 10 to 20%, and the fetal growth restriction is common. Some women with incomplete form of HELP, and there are different classification of this syndrome based on the platelet count and abnormality. So as the delivery is the mainstay of treatment for mothers, steroid should be given to help to mature for baby lung. You have to give the steroid for maturity of the baby lungs, not for the low platelet count. So it is usually the condition that usually resolve after delivery. So the plan is to do her immediate delivery in HELP care condition, and supportive care with fresh frozen plasma with or without precipitate if DIC is present. Platelet count should be maintained at more than 450. The condition usually improve quickly after delivery, although it may worsen during first 24 to 48 hour postpartum depending upon the clinical scenario. Worsen maternal condition or severe fetal growth restriction, delivery may be indicated at any time from 20 weeks of gestation. Conservative management for very early HELP is controversial, and difficult decisions sometimes have to be made between going extra time for the baby and maternal risk. So if the patient present with early HELP, so you have to balance the delivery. You have to balance between that whether we have to deliver the patient or not. So better option that early delivery in these cases because there is controversial that we have to proceed the pregnancy up to the term. The other condition, one of the cause of thrombocytopenia is microangiopathies, that is TTP, thrombocytopenia thrombotic purpura, life-threatening disorder with the characteristic pentate sign and symptoms. These are pentate signs that include anemia, thrombocytopenia, neurological symptoms, vary from headache to coma, renal dysfunction, and fever. So these are the 5 features for TTP. Etiology is that TTP has been due to severe deficiency of von Willebrand factor ADAM T313. This is most commonly an acquired deficiency caused by an autoantibody and rarely a congenital deficiency caused by genetic defect. The two types can be distinguished by measurement of ADAM T3 TS13 antigen activity inhibitor absent in the congenital form, and the lack of ADAM TS30 lead to persistence of ultra large multimer of von Willebrand factor that unfold and react with platelet receptors, resulting microthrombi in many organs. So with the deficiency of this lead to a large multimer of von Willebrand disease and lead to that react with a platelet receptor and microthrombi in many organs, particularly in the kidney, brain, heart, and causing microangiopathic hemolytic anemia. So these thrombi are deposit in different organs like kidney, brain. So that's why the kidney functions are deranged. So the patient may present with the neurological abnormalities, with fever. So these are the characteristic features of TTP. The incidence is 1 in 25,000 of the pregnancy, and usually the time of onset in pregnancy is variable, ranging from the first trimester to several weeks postpartum. Sometimes the patient may have underlying the present as a pre-pregnancy with TTP, and sometimes you diagnose the patient may present in pregnancy with TTP. So in review of 166 associated cases, 55% occur in third trimester. Maternal mortality was high, and particularly where preeclampsia was present. because the renal function are deranged. So in that case there is chance that the patient may develop in this patient may develop hypertension or later on develop preeclampsia. So there can be major difficulties in differential diagnosis of TTP, hemolytic uremic syndrome, HELP, and severe preeclampsia. The typical feature of these are listed in table 2 because they almost have same feature and very difficult to identify. So in that case, the specific classical features in TTP and preeclampsia you have to, because in preeclampsia there is increased PP, and in TTP there will be neurological abnormalities, deranged liver function, and fever. In preeclampsia there will be no fever, but with the TTP there will be fever, neurological abnormalities with that. So you have, it is a very difficult to differentiate between preeclampsia and TTP. So it could be one of the if the patient developing fever along with all the derangement of liver function test and renal function test, so that could be thrombotic thrombocytopenic purpura. Despite the management of diagnostic certainty, plasma exchange need to be commenced urgently, and good clinical judgment is required. So you have to, plasma exchange is very important because due to microthrombi. And using this procedure, antibodies are removed and 1 to 5 liter FFPs containing the absent enzyme is infused daily until the platelet count is normal and the LDH is reduced. So in this case, the LDH will also be, you will also perform our LDH and bilirubin level, they are increased in this patient. The number of treatment required is extremely variable, and high dose of steroid may be indicated. Rituximab, a monoclonal antibody, has been used successfully when improvement have been slow. About 25% of the women affected experience recurrent episodes. So in the rare conditional congenital cases, infusion of FFP rather than plasma exchange is required. So, since these women do not have antibodies, platelet transfusion are contraindicated because they are known to have precipitate or exacerbate CNS symptoms. So, this is one of the important part, that you may not give platelet transfusion because there is no antibodies against the platelets. So, in that case, it is contraindicated. A central line should be placed without platelet support. High risk of bleeding is low. In this condition, predictor of relapse include previous clinical presentation, low level of ADAM TS13 while in remission. So, in that case, you will aggressively treat with plasma exchange or sometime may need of steroid. The other condition is hemolytic uremic syndrome. This is similar syndrome with microangiopathic hemolytic anemia and thrombocytopenia with a predominant liver involvement. In childhood, the disorder usually associated with E. coli infection and a good outcome. In adulthood and pregnancy, there is a poor response to plasma exchange. So, hemolytic uremic syndrome, there will be a history of any infection to E. coli. Microangiopathies and neonatal issues. The prognosis for the baby in all microangiopathies described is poor because of the extensive placental ischemia. Because microthrombi form and it lead to ischemia, so in that case the neonatal outcome will be poor. DIC can complicate the picture and exist secondary to other causes and usually associated with bleeding. Then this is the table that how to differentiate different form of characteristic form of TTP, HUS, HELP, and preeclampsia. How to differentiate this? So onset would be in TTP anytime, HUS usually postpartum, in HELP third trimester, and preeclampsia third trimester. In TTP there will be no hypertension, HUS no hypertension, but with HELP there may be plus minus hypertension, and preeclampsia obviously increased BP. MAHA thrombocytopenia there will be present, HUS thrombocytopenia, HELP, and in the preeclampsia there will be also thrombocytopenia. And microangiopathic hemolytic anemia is more common in TTP, HUS. In HELP there may be microangiopathic hemolytic anemia, but in preeclampsia it could be plus minus. DIC, in TTP there will be no chance of DIC. In hemolytic uremic syndrome there is chance plus minus. HELP there is chance of DIC, and preeclampsia plus minus. Liver disease, TTP plus minus HUS plus minus, but with help there is liver disease, the ALT and AST will be deranged, and in preeclampsia plus minus. Renal disease TTP plus minus, in HUS the predominant feature is involvement of renal function, and help there is slight changes and preeclampsia also. CNS disease more predominant in TTP and plus minus in HUS, HEL plus minus, and preeclampsia plus minus, but it is more predominant in TTP. So management in TTP is plasma exchange. Hemolytic uremic syndrome, you will give supportive treatment. In HELP syndrome, you will deliver the fetus and give blood products, and preeclampsia, you will deliver the fetus. So these are the differentiating point. These are the causes of thrombocytopenia, and how will you manage, how will differentiate from gestational thrombocytopenia, ITP. So these are very important table. So you have to differentiate between different. So other causes are antiphospholipid antibody syndrome. Thrombocytopenia can be associated with APLS, but it is rarely severe. In primary APLS and SLE with APLS antibodies, women need aspirin and Clexane. So during pregnancy, there has been shown to give better outcome. Occasionally, thrombocytopenia can make this treatment more difficult to achieve. So could SLE, where SLE associated with SLE and along with that APLS, so there is chance of thrombocytopenia. So in that case, you will prescribe aspirin and Clexane. Viral infection. Almost any virus can cause reduction in platelet count. The usual very transient, but there may more prolonged reduction of number of weeks. HIV and cytomegalo are particularly associated with thrombocytopenia and should sought be appropriate. Medication, important cause of thrombocytopenia, commonly used drugs. Heparin-induced thrombocytopenia can rarely occur with administration of unfractionated heparin, but cannot be described with low molecular weight heparin. So you have to tell the detailed history of the drug. With unfractionated heparin, there is chance of thrombocytopenia. So you have to take the detailed history that whether she unfractionated heparin or low molecular weight heparin. Other causes, they are rare and include constitutional and those due to hematological malignancy. They are less likely. So what is the fetal and neonatal thrombocytopenia? How the topic deserves a separate review. However, it needs to be emphasized that thrombocytopenia in pregnancy can affect the fetus. The reduction in platelet count that can be occurred in maternal ITP has already been described. In fact, in normal gestational thrombocytopenia, no effect on the fetus. But in ITP and other angiopathies, there is effect on the fetus. So infection of the fetus can lead to reduced platelet count. A serious cause of fetal and neonatal thrombocytopenia is fetal and neonatal alloimmune thrombocytopenia. So this is one of the condition that FN8. Fetal neonatal thrombocytopenia. In this condition, the maternal platelet count is usually normal, but antigen on the fetal platelets that are not present on the maternal platelets cause the development in the mother of antibodies that cross the placenta and destroy the fetal platelet. So FN8 is a condition, a severe serious cause of fetal neonatal thrombocytopenia. In this, the maternal platelet count are normal, but in that there are certain antigens on the fetal platelets that will cross the placenta and that will mix in the maternal blood, and the maternal blood will cause antibodies against this. So the antibodies again reverse back to the placenta to the baby and lead to fetal thrombocytopenia. So in this case, the main condition in the fetus platelet count, that the antigens are formed against the fetal platelets. So this is a different condition. You have to memorize this. This is because with the ITP, the main problem is in mother. The antibodies are formed against the mother platelets, but in FN8, the antigens are formed against the platelets of the fetal, and they will enter into maternal circulation, and in maternal circulation they form antibodies, and the antibodies reverse back to the through the placenta to the fetus, and that cause thrombocytopenia. This is the platelet equipment of RH, rhesus hemolytic disease of the newborn. Intracranial hemorrhage is devastating consequences of this condition. A large literature review identify occurrence in 26% of the cases. Approximately 80% of the hemorrhage occur before birth, 14% before 20 weeks of gestation. Prompt recombination of FN8 in the neonate and treatment with appropriate matched platelet improve outcome. Counseling of the pregnant regarding recurrence should be undertaken. Various antenatal management regime are in use, none of which are ideal. This include high dose of IV immunoglobulins with or without prednisolone or a serial fetal platelet transfusion. So this is the treatment for FN8, that you will give her high dose of immunoglobulins through fetal umbilical cord.